Good evening, everyone. So we'll be starting off with a presentation. So the topic of presentation is outcomes of patients with elevated pulmonary artery systolic pressure on echocardiography due to chronic lung diseases. So a brief introduction. Lung diseases such as interstitial lung disease, chronic obstructive pulmonary disease, and hypoventilation, obesity hypoventilation are labeled as group 3 pulmonary hypertension and are the second most common category of pulmonary hypertension that we have seen. Pulmonary artery systolic pressure on transthoracic echo is a surrogate marker for invasive pulmonary artery measurement, with a pulmonary artery systolic pressure greater than 35 is mostly considered elevated. Cardiac cath is the gold standard to identify pulmonary hypertension in low to middle income countries. Transthoracic echo is commonly used to diagnose pulmonary hypertension, but due to limited resource stuff, only a minority of patients undergo right heart catheterization. So background data from the United States surveillance data, approximately 26% of mortality from pulmonary hypertension is due to lung diseases. The pulmonary hypertension due to lung disease is common, heterogeneous, and with poor outcomes. So study objectives were, the objective 1 was to identify all-cause 1-year mortality data of chronic lung disease patient with pulmonary artery systolic pressure elevated on echocardiography. And our secondary objectives were to identify the 1-year hospital readmission rates for patients who are having pulmonary artery systolic pressure and pulmonary hypertension. What were the difference in outcomes with patients who had similar disease with pulmonary hypertension and similar disease without pulmonary hypertension, and diagnostic and treatments done. Inclusion criteria, retrospective chart review. We took adult patient greater than 18 admitted to a hospital from June 2012 to May 2021. So roughly it was a 9-year study. Inclusion criteria, transthoracic echo measurements of the pulmonary artery systolic pressure greater 35 were included in that study group, and exclusion criteria was group 1 pulmonary hypertension or cardiac etiology of elevated pulmonary hypertension or unclassified cause of pulmonary hypertension. So we excluded these patients from our study and we only took group 3 pulmonary hypertension. Our study arm, so a control arm was made of patients who had pulmonary artery systolic pressure less than 35, and it was matched to the same chronic lung disease patients. And we choose random patients who came to the were admitted to the hospital to the same time period and the same disease diagnosis. So we took patients who have COPD with pulmonary hypertension, and we simultaneously took patients COPD without pulmonary hypertension. So but statistical analysis with a chi-square test was performed to compare different populations with elevated pulmonary systolic pressure and associated factors associated with the 1-year mortality and 1-year readmission rate, and the logistic regression model was fit in. So this is, we can briefly overview through the chart and use a pointer for this. So admitted inpatient to the hospital from 2012 to 2021. So patients with echocardiographic features are having pulmonary hypertension. 1,501 patients were included. 19 patients had group 1, so we excluded them. 1,361 patients had group 2, so we excluded them as well, and we only included 128 patients in our study cohort. Then we had patients who had echocardiographic features less than 35 pulmonary systolic pressure, and they were patients who had between COPD, ILD exacerbation with OSA, OHS, and then bronchiectasis, and then these are only 128 patients included in the control arm. So there was a head-to-head comparison trial of 1:1. So let's do the study characteristics. So we clearly see patients had etiological features. So the study arm had COPD patient was 17, head-on trial 17, interstitial lung disease 23, and then we had patients female and male ratio. The female patients were 89, and then 67 were in the control arm. For bronchiectasis, so we took patients who had post-TB bronchiectasis, who had ABPA, who had idiopathic and cystic fibrosis. So we included all these 4 causes of patients who had bronchiectasis underlying. Then we took obesity, hypoventilation syndrome, patients with pulmonary embolism, and obstructive sleep apnea. So a graphical representation, so this is just a rough graph to see what are the expected pressures you see patients in different etiology. So roughly you'll see patients who were coming in with bronchiectasis, they had pulmonary systolic pressure rough around 60. And then COPD patient had numbers around 50 to 60, and then ILD patient had around 60 to 70 of pulmonary systolic pressure, and patients who have CTAF had again pressures between 60 and 70. So these were rough numbers, and we'll be highlighting our results at why we were highlighting these in our population. So this is a study arm. So you see pulmonary artery systolic pressure 59 and plus minus 16.5, and the control arm had 20.9. We stratified them into mild, moderate, severe. We took severe patients, there were 39 in our control arm with a tricuspid regurgitation of 19 patient had this, and then moderately reduced RVSF patients were 38 in our study arm. And then we took patients who have pro-BNP baseline. There were 1366 and then 134.5 in the comparison arm. So what do we found? So we found that 1 year hospital mortality and 1 year hospital readmission rates were higher with patients who had pulmonary hypertension. Readmission rates were around 41.2% as compared, and the mortality was 11.8% with patients who had pulmonary artery hypertension. Simultaneously, we saw patients who were coming with bronchiectasis. They had readmission 1 year around 71.4%, and then they had 45% patients who were having mortality. So what do we see on outcomes? So on outcome, you see the study arm, patients were diuretics. You see 58 patients were on diuretics, and the 1 year mortality after diagnosis were 26. So these patients who were studied had that higher mortality, and then these patients had readmission rates, they had suffered from more diseases, and they had higher mortality as compared to the control arm. This signifies that patients with pulmonary artery systolic pressure and with pulmonary artery hypertension, these patients are at prone risk of readmissions. They have got higher mortality as compared to the other patients with similar diseases. Then 1 year hospital readmission rates. So there were 60 readmission rates with patients with pulmonary hypertension in our study group, and the control arm had 43. Out of them, obesity, hypoventilation had 18 patients. We had 18 readmissions in 1 year, and higher was on bronchiectasis as well. So our p-value, so you see there's a statistical significance in our p-value in different populations. You can see ILD had 0.006, statistically significant as compared to the p-value of 0.02 with malleable analysis. And then we had patients who had bronchiectasis, again a very good significant statistical p-value as we have highlighted in 0.02. So there were some limitations to our study. So our study was performed on patients that were admitted to hospital. Therefore, these findings cannot be generalized to patients like outpatient basis who had systolic, who had pulmonary arterial hypertension. 31.3% did not have ideal pulmonary hypertension workup, as only 68 patients had workup to exclude pulmonary embolism. However, this was mainly because these patients had significant bronchiectasis or ILD. Therefore, the main driver for the pulmonary hypertension was felt to be underlying lung disease. This is what we thought, because the patient were not suitable for workup and they were not willing to it, and they had a significant end-stage lung disease because of ILD and bronchiectasis. So conclusions, so our study indicate a higher 1 year mortality and 1 year hospital readmission rate for patients who have pulmonary higher hypertension. Patients with bronchiectasis and ILD are found to have the highest odds for worse 1 year outcomes, and OSA, OHA have lower mortality. So this signifies also that another outcome of our study was when you see patients who have got a different set of pressures in pulmonary hypertension. So you expect patient with COPD, he will have a pulmonary hypertension for around 60 pressures, but he comes to a clinic or he comes to the hospital and he has a pulmonary hypertension of 90. So that makes you think out of the box that the patient expected pressure is 60, but he has came at 90. So you need to rule out other stuff in the patient. Maybe it has concomitant group 1 pulmonary hypertension, or maybe some other etiologies as well. Thank you.